Today we are going to talk about third heart sound and fourth heart sound, right? Before really we go for detail of genesis of third heart sound and genesis of fourth heart sound, let's little bit review other first and second heart sound in relation to that. As we know that here is your timeline, and let's put it here systole. What is this? Ventricular systole. And here is ventricular diastole. Let me draw three cardiac, again systole, and there is diastole. Let's suppose that this patient has a heart rate of 72, then its cardiac cycle duration will be 60 divided by 72, that is 0.8 second. And normally, again, if heart rate is 72 per minute, naturally then you will say that one cardiac cycle will be 60 second divided by 72, about 0.8 second. Out of this 0.8 second, 0.3 second will be systole and 0.5 second will be diastole. So this is 0.3 second and here it is 0.5 second. Then again 0.3 second systole, 0.5 second. And let me draw one more systole and diastole. Now, as we discussed in previous lectures, that at the onset of, I will go to third and fourth heart sound, but I will just do very brief review of other heart sounds also, S1 and S2. That S2 sound, you know, when you put your stethoscope to the chest precardium, you hear the sound loop, dup, loop, dup. Loop is the first sound and dup is the second heart sound. First heart sound appears at the beginning of systole. This is first heart sound, and why it is there? Because at the beginning of the systole, when ventricle contract, when I talk about systole and diastole, actually I am talking about in this lecture ventricular systole and ventricular diastole. Now, at this moment what really happens that when ventricle contract, right, when there is onset of ventricular contraction, right, pressure in the ventricle goes up and closes the mitral valve on the left side and closes the tricuspid valve on the right side. Is that right? So this is rising intraventricular pressure at the beginning of systole, which closes mitral valve on the left side and closes the tricuspid valve on the right side, and this closure produces S1. That produces S1. So S1 is due to closure of mitral and tricuspid valve. Then after that, after the closure of these two valves, further increase in ventricular pressure opens the aortic valve and pulmonary valve, and these semilunar valves open without producing any sound. Let's suppose at this moment, but without producing any sound, they open silently. At the end of the ventricular systole, at the end of the ventricular systole, what happens when ventricles start relaxing? The blood in aorta and pulmonary artery reverses and closes what? Now, actually what happens? At the beginning of systole, which valves are closed? And tricuspid, right? Then, okay, if I draw only the left side, then next stage, here is that aortic valve and pulmonary valves are open and blood is being ejected. Blood is being ejected into major arteries. After that, at the end of the ventricular systole, let's suppose we put it ventricular systole end. At the end of the ventricular systole, what happens that when ventricles start relaxing, blood in aorta and pulmonary artery reverses, and that closes aortic valve and pulmonary valve, and this is a closure of aortic valve and pulmonary valve, which represents which leads to genesis of second heart sound. So what we can say that first heart sound is due to closure of AV valve, mitral and tricuspid at the beginning of systole, and at the end of the systole, closure of which valve? Aortic and pulmonary. That is produces which sound? S2. Is that right? Now, again, S1 represents the onset of ventricular systole, S2 represents the offset of ventricular systole. After that, ventricular diastole comes. When I say there is ventricular diastole, it means ventricles are relaxing and then AV valve will open. I will draw now 3 phases of ventricular diastole. What happens during ventricular diastole? First is that, of course, aortic valve and pulmonary valves are closed. And which valve open?
Mitral.
Mitral on left side and tricuspid valve on the right side open. The opening of this valve lead to filling of the ventricle. But before this valve open, ventricle had some blood left from previous cycle, and that blood is called end systolic volume. At the end of the systole, right, some blood was still left in the ventricle, right? Then when ventricles start relaxing, AV valve open, mitral valve and tricuspid valves open. When these valves open, the blood which was present in, what is this? Atrium, left atrium and right atrium, right? Which was, this is the amount of blood which was being received previously from the lungs on the left side. And when ventricular systole was going, a mitral valve was closed and this blood was accumulating here. When ventricular ejection phase was going, during that time, whatever venous return was coming to the left atrium or to the right atrium, that was being accumulated, that was being stored into both atria. So during the ventricular systole and ejection phase, as AV valves were closed, blood which was returning to the atria, then atria was acting as a storage of or reservoir of blood. The moment ventricles start relaxing and mitral valve and which other valve open? Tricuspid valve open, then this accumulated blood will start rushing to the ventricle. Right? This early stage of ventricular diastole is called rapid inflow stage. What is it? Rapid inflow stage. So it means in the beginning of the ventricular systole, there is rapid ventricular filling, right? Why this rapid ventricular filling is there? Because both atria were accumulating the blood during ventricular systole, and as soon as mitral valve and tricuspid valve open, this blood in distended atria rapidly fall into ventricle. Is that right? Right now atria is not contracting. It is just opening of the valve and accumulated blood goes into ventricle. Is that right? Now, in younger adults, when blood is coming into ventricle, what happens? Ventricular volume is increasing. What is happening? Ventricular volume is increasing. When ventricular volume is increasing, then pressure on the walls of the ventricle is increasing. So ventricle goes under some distension. During rapid inflow phase, as more and more blood is rapidly coming, right, ventricle undergoes distension, right? By the end of rapid inflow, ventricle has reached its elastic limit to stretch. So it cannot stretch with further rapid inflow. When ventricle cannot stretch with further rapid inflow, but rapid inflow still come, that will lead to vibration of the taut walls of the ventricle. I will repeat it, it's worth repeating. When mitral, suppose we talk about the left ventricle, but same is true about the right ventricle too. Left ventricle, when mitral valve opens, accumulated blood rapidly enter into ventricle. This rapid entry of the blood, if this is ventricular walls, this rapid entry of the blood gradually distend the ventricle. If by the end of rapid ventricular filling, walls of the ventricle have reached their elastic limit, right, and they cannot further distend. At that very moment, we say the walls of the ventricles are no more loose, they are taut. What are they? Ventricular walls are taut. When ventricle walls are taut due to rapid infilling, rapid rush of the blood, once they become taut, right, now further rapid inflow will lead to vibration of the ventricle, and this vibration of the ventricle will produce third heart sound. So if someone asks you, what is the cause of third heart sound? Very simple answer. Very simple answer. There is rapid, in the early part of diastole, ventricular, in the early part of ventricular diastole, when there is rapid ventricular inflow, then taut ventricular walls vibrate, and these vibrations produce third heart sound. They produce third heart sound. Very good. Is it clear? Now, this third heart sound is very soft. It is low pitched. What I'm saying, this is low pitched, and it is very low frequency, low pitched, and very soft, right? That is why it should be heard with what? Bell, not with diaphragm. As you know, stethoscope diaphragm is designed to pick up the high frequency sounds, and stethoscope bell is designed to pick up soft sounds, soft rumbling sounds, soft, low pitch, low frequency sounds. As S3 is produced over here, right? And this S3 which is produced over here, right? What is the cause of this S3? Rapid ventricular filling in a distended taut ventricle. Rapid ventricular filling in early diastole in the distended taut ventricle, which vibrate and produces third heart sound. Is that right? Now, this third heart sound, as I told you, that it is in early diastole. How you will hear it? Now listen carefully. How you will hear it? Normally you hear, if there is no third heart sound, now I will repeat, if there is no third heart sound, there is only S1 and S2, then what you will hear? S1, S2, S1, S2, right? And these are what? Ventricular systole. Again ventricular filling phase, and then ventricular ejection systole, then diastole and systole. Now if there is no third heart sound, what you hear? You hear loop dup, loop dup, loop dup, right? But if there is very rapid ventricular filling in early diastole and distended taut ventricle vibrates and produces third heart sound, which sounds? Third heart sound, then what you will hear? Suppose in this patient third heart sound is being produced, right? And here is also, and of course this sound is in diastole and early diastole. And remember, the duration between loop and dub present systole, and duration of dub to the next loop, that is diastole. Now if third heart sound is present, how it will sound to your ears? It will be loop dup ta. An extra sound is there. What is this? Extra sound. But it is in early diastole. If this is early diastole, then it will be with S2. If there is some sound in late diastole, that will be with the next S1. But as it is early diastole, how you will hear? Loop dup ta, loop dup ta, loop dup ta, loop dup ta. Is that right? So normally loop dup, loop dup, loop dup, loop dup. This is normal. If there is addition of third heart sound, loop dup ta, loop dup ta, loop dup ta. Is that right? Now, if you hear this sound, loop dup ta, right? We call it S3 gallop. What we call it?
S3 gallop.
S3 gallop. Actually, to our previous generations of doctors, when they put stethoscope here, they heard as if horses are galloping, and they thought that loop dup ta is just a sound. This sequence of sound is as there are hooves, sounds produced by the hooves of running horses. So that is why it was called S3 gallop. And because this is due to rapid ventricular filling, it is also called ventricular gallop. What is it is called? Ventricular gallop. Right? It is also called ventricular gallop. Is that right? Now, I will tell you the mechanism of fourth heart sound. This was the mechanism of third heart sound. Let's compare the mechanism of fourth heart sound. Okay, for this purpose, I will again draw the ventricular. What happens during ventricular systole? What happens during ventricular diastole? Right? Actually, ventricular diastole for functional purposes can be divided into three parts: early 1/3, middle 1/3, and late 1/3 of the diastole. Early 1/3, I told you what was happening in early 1/3. There was rapid ventricular filling. What was there in early? There was rapid ventricular filling, and this rapid inflow, as we discussed in early stage, right? As we discussed, this rapid inflow will produce third heart sound in early diastole. Clear? Now what happens during middle diastole? Now before the middle diastole, okay, this is little bit distended now. Now, during the middle diastole, of course, these valves are still open, right? But all the blood which was previously coming from the ventricles to the left side and systemic blood from the right side, that blood which was accumulated during the ventricular systole, that blood has been shifted to ventricle. During rapid ventricular, what is this? Rapid ventricular filling. Once all that blood which was accumulated has been shifted to, this was the blood, this has been shifted during rapid ventricular inflow. After that, there is slow ventricular filling, very slow. Question is that why previously it was rapid filling, why in the middle it is slow? Answer is very simple, that previously blood was accumulated with rushed in, but at this time, as there is no accumulated blood, but from the venous return, the blood which was coming from the venous return, right, that is just now during middle diastole, accumulated blood is already here. Now the more blood which is coming, that is coming, the venous return coming to the atria, and now atria is not acting as a store. Whatever blood is coming, as it is coming, it is moving forward into ventricle. So as compared to previous situation where there was accumulated blood, this inflow of the blood into ventricle will be slow, and this stage is called diastasis. What is it called? Diastasis, middle of the slow ventricular filling. Of course, on the left side it is pulmonary venous return, on right side it is systemic venous return. Is that right? Now, usually this slow filling does not produce any sound. So middle of the diastole or diastasis phase is silent. Small amount of blood gradually coming in. Clear? Now what happens? The third stage of ventricular filling, or the last stage of ventricular filling, at just before the ventricular contraction, right, there's last stage of ventricular filling. What happens in last stage of ventricular filling? Now ventricle had, number one, the blood which was left from the previous cycle. What was that blood called? And systolic volume. Then there was addition of this blood. What was it? During rapid inflow. right? So this was the blood which was added during rapid inflow. Then this was the blood which was added in the middle of the diastasis. After that, what happens? Suddenly ventricle contract, atria contract. This is the time when atria contract. Now why at the end of ventricular filling time, why atria need to contract? Why atria should contract? Atria has to contract to do additional final filling of the ventricle. Final filling of the ventricle just before the next systole. Last filling of the ventricle. And why this last filling is required with atrial contraction? Because due to previous filling, pressure in ventricle is slightly up. So atria has to push the blood into ventricle, and this last part of the blood which atria is pressurizing and comes over here, this is called last ventricular filling due to atrial contraction. Some nasty people call it, this is atrial kick. Atria put a kick to the last amount of blood. It kick it at, I don't know, it kick it on its butt or where, but atria kick on the remaining small amount of blood into ventricle before the valve closes because of onset of ventricular systole. So what did I say? There are 3 stages of ventricular filling. Rapid ventricular inflow produces which sound? S3, especially in young people physiologically. Then middle phase where slow ventricular filling, usually silent. And then in the end of the ventricle, the last filling is done by atrial contraction or by atrial kick to fill the already distended ventricle which has slightly high pressure. Done? Now, in healthy person, even though I would say atria contracted here, even though atria contracted here, and this blood was pushed with atrial contraction, but if atria and ventricles are healthy, this last filling will be also silent. This last filling will be also silent. But if due to some reason, now listen carefully, if due to some reason, if left ventricle is or right ventricle is hypertrophied or it is stiffened, this ventricle is stiffened, this ventricle is hardened. Usually it is seen in those patients where there is left ventricular hypertrophy. Right? In left ventricular hypertrophy, ventricle is hardened, stiffened. It does not expand properly. Is that right? Or in recent myocardial inactive myocardial ischemia, when a big part of myocardium is ischemic, it does not relax well and even does not contract well. And during diastole, if ventricular part or the whole ventricle does not relax well, it offers more resistance. So those patients in which left ventricle is stiff, right? Stiff left ventricle. In third heart sound, it was distended left ventricle, distended, right? Dilated, distended left ventricle. Here it is stiffened left ventricle. So in the last part of the diastole, in those patients where left ventricle is stiff and does not distend well, atria had to contract more strongly than normal to push the blood. Those patients in which left ventricle is stiffened, right? Atria, because if it is stiff, it does not distend. If it does not distend with initial filling, pressure in this area becomes significantly high. Then atria has to push the blood with strain. When atria are straining against a stiffened ventricle, that may lead to again ventricular vibration, and that vibration may produce a sound called fourth heart sound. What that vibration is called? Fourth Hard sounds that may produce low pitched sound, which is S4. Now you can look at it. S4 is produced just before the next ventricular systole, because once the atria contract, push the blood here. After that, ventricle contract and close the valve and push the blood into aorta or major arteries. Is that clear? S4 is always abnormal. S4 is produced by the end of, in the last part of ventricular filling stage. It is produced in the last part of ventricular diastole. Or we can say this sound is produced just before next systole. Because this sound is produced just before next systole, this sound is called pre-systolic sound also. Right? Because it will result from pre-systolic distension of ventricle, but when strong contraction of atria is straining to fill the stiffened ventricle. Is that right?
Yes.
So now you understand. Up to now, what did we learn? That, let's compare it. Third heart, few things are common in third and fourth heart sound, and few things are different. Up to now, what we did learn, third heart sound and fourth heart sounds, both are produced during ventricular filling, that is ventricular diastole. Third heart sound is produced in early diastole, fourth heart sound is produced in late diastole. Third heart sound is produced due to rapid influx of the blood, rapid filling of the ventricle, right, into distended dilated ventricle. Is that right?
Yes.
Third heart sound is produced due to rapid ventricular filling stage, when blood is entering into ventricle and ventricular walls have become taut. Is that right? Fourth heart sound is produced only pathologically when atria just before the next, atria at the end of the ventricular diastole, atria contract forcefully to fill the stiffened ventricle. Is that right?
Yes, sir.
So this is early diastolic sound, this is late diastolic sound. It is rapid ventricular filling leading to ventricular vibration. Here strong atrial contraction leading to stiffened ventricular vibration. This is called what?
S3.
S3, that is called?
S4.
Of course S4. Any question up to this? Now, let me show you some interesting pattern. Right? Let's suppose I'm going to draw here 4 patterns of these sounds. Now this is ventricular systole. What is this? Systole, then diastole, then systole, then diastole, and then systole. Remember, right? Now, S1, S2, lobdub, ta, lobdub, ta, lobdub, ta. What is this gallop? It is, what is this sound? S3, right, in early diastole, just after the dub, So what we'll call it? S3 gallop,
Ventricular gallop.
or other name is ventricular gallop. Or it is also called early diastolic gallop. Is that right?
Yes, sir.
Now we think of another patient where the problem is that ventricle are stiffened, right, and atria contract, last part of ventricular diastole, atria contract strongly, so they have to strain against now this sound. Here in last part of ventricular diastole, if atria has to strain strongly against a stiffened ventricle, an additional sound is produced. What is this sound?
S4.
S4, right? This is S4. S4 comes just before the next systole. S3 comes after the systole.
Yes.
S3 comes after the systole. S4 comes just before the next systole.
Yes.
Is that right? Now S4 is late diastolic sound or pre-systolic sound. Now this will not, if there was third sound, it was loop dup ta, loop dup ta, loop dup ta. Is that right? But here, because fourth heart sound is just before the ventricular systole, so it will be ta loop dup, ta loop dup, ta loop dup. Is it clear?
Yes.
So if pattern is loop dup ta, loop dup ta, loop dup ta, third heart sound. And if pattern is ta loop dup, ta loop dup, ta loop dup, fourth heart sound. So this will be considered what?
Fourth heart sound.
This will be considered as 4 gallop, or it will be considered atrial gallop, because it is due to atrial. It is initiated by the strong atrial contraction, but it is also sound is even here produced by the vibration of ventricle. Here the ventricle vibrates due to rapid inflow. Here, okay, here distended taut ventricle vibrate due to rapid inflow. Here here stiffened ventricle vibrate on strong atrial contraction. So even though we call it atrial gallop, but this sound is still produced by the vibrations of stiffened ventricle. Here it was vibration of no. Here it was it was vibration of distended taut ventricle. Here it is vibration of stiffened, hypertrophied, or right ventricle on strong atrial contraction. Now we know. I will repeat these sounds. So this is S4 gallop, or it is also called atrial gallop, right? I will repeat and you will tell me which sound. If you are putting stethoscope here on the apex beat and you have applied what? Bell. Usually if you have to hear the S3 and S4 sounds on the left ventricle, if you want to hear the S3 and S4 sound in the left ventricle, then you should ask the patient to lie down in the bed and turn in left lateral position. This is called left lateral decubitus position. What is it? Left lateral decubitus position. The left lateral decubitus position, you should palpate where is the apex beat and put there your bell, right? Your bell means stethoscope bell. Softly, because if you apply the belt hardly, then skin is caught at the margin and it converts into diaphragm. So put your stethoscope bell lightly, softly, and then auscultate, right? For the left-sided S3 or S4. Now you will tell me which sound you are hearing. If you are hearing loop dup ta, loop dup ta, loop dup ta, third heart sound. And if you hear ta loop dup, sound just before the loop dup, ta loop dup, ta loop dup, ta loop dup. What is it? Fourth heart sound. S3 gallop and S4 gallop. But remember one thing, these sounds may be present even though less often on the right ventricle also. And if you want to hear S3 or S4 sound generated in the right ventricle, then patient should be lying on his back spine, and you should put your bell in fourth intercostal space, left parasternal or left lower parasternal border, where there is right ventricle most near to the chest wall. If you put it there, then if you hear third or fourth sound, these are right-sided sounds. What are these? Right-sided sound. But if you hear such sounds, diastolic sounds, soft rumbling on the apex beat, then these are left-sided sound. Then they are left-sided sound. Here I want to mention another thing. If you want to increase the intensity of the left sound, if you want to increase the intensity of left sound to hear it better, these are very difficult to hear, these sounds. But anyway, if you want to increase the intensity of, or you want to hear it properly left, not only you ask the patient to be in left decubitus position, ask the patient try to auscultate during expiration, because during expiration lungs go on the side and apex beat become more near to the chest, plus during expiration lungs are squeezed to push the air out, but when lungs are squeezed during expiration, even pulmonary circulation is also compressed and more blood go to the left side, and these sounds become accentuated, right? So if you have to hear left-sided S3 or S4, what is the position? Left lateral decubitus position. What is the point? Apex beat where you feel, right? Which side of that stethoscope? Bell. Is that right? Lightly applied. And if you hear lup dup ta, lup dup ta, lup dup ta, it is third heart sound. If you hear ta lup dup, ta lup dup, ta lup dup, it is fourth heart sound. But if you are going to hear the right-sided ventricular sounds, S3 or S4, you have to put your stethoscope, ask the patient to be in spine position. Patient in spine position. Bell of the stethoscope applied. Softly, very good, at left lower sternal border. Is that right? And try to hear these sounds during inspiration. Why? Because during inspiration, there is more venous return to the right side. So if sounds are there, they will be little more loud and you may hear, you have more chances to hear them. Clear?
Yes, sir.
Now, so this is triple, this is also called S3 rhythm, this is called S4 rhythm, S3 gallop, S4 gallop, ventricular gallop, atrial gallop, early diastolic gallop, and this is pre-systolic gallop or late diastolic gallop, right? Now I come to another situation. Sometimes we come across a patient who has third sound as well as fourth sound. It means that in that patient, okay, first let me draw here. Again, what is this? Which systole? Atrial or ventricular? Yes. Ventricular systole, again ventricular systole, and next cycle again ventricular systole. Lob, dub, lob, dub, lob, dub. Now you add the third heart sound. Lob, dub, ta. Lob, dub, ta. Lob, dub, ta. Right? But in some patient, ventricle is seriously dysfunctional. If ventricles are seriously dysfunctional, not only they produce third heart sound, they also produce fourth heart sound. Third heart sound is produced when there is volume overload. Classically this is seen, third and fourth heart sound, in patients with congestive cardiac failure, right? Both sounds could be there. Or where ventricle severe dysfunction is there. So at distending, when ventricle is filling and distending, at that time it produces sound, and atria has to contract very strongly to push the blood into ventricle, again another extra diastolic sound. So if these patients have extra sound, then it will become loop dub ta ta. Loop dub ta ta, third and fourth. Loop dub ta ta. Right? This is called quadruple gallop. This is quadruple gallop. Now quadruple gallop is a dangerous sign, especially when you are working in coronary care unit, right? In patient with in coronary care unit, where many patients have active ischemia, right, or recent ischemic problem in the heart or MI, right? Either onset of third heart sound, new third heart sound, it is a dangerous thing. Or especially if third and fourth both are present, it is very dangerous situation. If you are here able to hear lup dup tata, lup dup tata, lup dup tata, I think you have to call some senior cardiologist, whosoever you can get around. There is something seriously wrong with ventricular function, right? And if there is very unfortunate situation and it happens in these patients, at the top of this quadruple gallop, if patient goes into tachycardia, especially ventricular rate becomes more than 120 beats per minute. When ventricular tachycardia is there, total cardiac cycle duration is reduced. Systole duration reduces slightly, but diastole shrink too much. Right? So what happens? If there is tachycardia, it means ventricular systole, other systole come very rapid, then another systole come very rapid, and then another systole come, and so forth. Now in these patients, if there is severe ventricular dysfunction, not only you will hear loop dub, but you will hear extra third and fourth sound. But as diastole, look here diastole was long, here diastole was long, here diastole is shortened, right, due to tachycardia. If diastole is shortened, these two sounds become very near to each other, because rapid ventricular filling will still occur and atrial contraction will still occur, but diastasis will be shrunken, and these two sounds in tachycardia will become very near. If these two sounds become very near, what you will hear? You will hear third sound, right? In diastole you will hear third sound, and along with that, right, almost at same time you will hear fourth sound also, and in severe tachycardia, third and fourth sounds will fuse and produce a single sound. These two sounds will summate. Third sound and fourth sound will make a summation. They will add to each other and produce a loud sound. In this patient, when this loud sound is there, you will not hear lup dup ta ta. No, this ta ta will become together. So it will become lup dup ta, lup dup ta, lup dup ta, lup dup ta. Right? This is more dangerous even, right? And this situation is called summation gallop. Summation gallop. Right? This is called summation gallop. Right? Again I will repeat. What is summation gallop? A patient who has not only first and second heart sound, but of course everyone has first and second heart sound if he is healthy, but these patients have extra diastolic sounds, S3 and S4 both, but at the top they have tachycardia, due to which diastole become very shortened, and early systolic sound S3 and late systolic sound, early diastolic sound and late diastolic sound move to each other and they summate. So this is called summation gallop. Now I will repeat. You will tell me which pattern is going on. You are putting stethoscope to the apex area with bell. Patient turned left lateral decubitus, and you are trying to hear during expiration. If you hear, you will tell me, you will diagnose. If you hear lup dup ta, lup dup ta, lup dup ta, what is it? Third heart sound. Right? Or simply call S3 gallop. What is it? S3 gallop. Now, ta lup dub, ta lup dub, ta lup dub, ta lup dub. S4 gallop. Very good. If you hear lup dub tata, lup dub tata, lup dub tata, quadruple. And if you hear lup tha, lup dub tha, lup dub tha, lup dub tha, lup dub tha, summation gallop. One of the features of summation gallop is that this summated sound may be louder than lup and dub. Is it clear? Yes. Any question up to this? After this, we come to what are the different causes of S3 and S4, right? Now S3 can be physiological. It may be normal in your age up to 40 year, 30 to 40 year of age. S3 may be normal because in younger age, ventricles are little more compliant, and due to rapid ventricular inflow, compliant ventricle becomes slightly distended and then vibrate, right? But as you age, you lose many things. As I have lost my hair, right? As you age, you lose many things. One of those is normal S3, and you should lose. After you are 40 plus, you shouldn't have S3. But if you lose and after 5 years again come back, this is a bad sign. There is something wrong with your heart. There is something wrong with your heart. So what I will say, causes of third heart sound. First of all, causes of third heart sound. Number one, they can be physiological. Physiologically, third heart sound is heard in children. Very pliable heart, young, right? Also pliable heart up to the age of 30 to 40, right? An older age, heart become a little stiffened, less pliable. And when it becomes less pliable in older age, then S3 disappears, right? Then pregnancy, third trimester of pregnancy. Remember, to generate the third heart sound, there are two conditions. Number one, ventricle should be pliable, distendable. Secondly, there should be rapid inflow. You know, pregnancy is third trimester of the pregnancy is a volume overload condition. There is excessive fluid in the body. So, in pregnant women in third trimester, you may hear S3. Rapid ventricular filling with distending the heart and vibration of the ventricle may be audible here as third heart sound. Is there pregnancy is physiological state or pathological state?
Physiological.
Yeah, physiological. Thank God you know it, especially in women. Okay, but maybe if a man gets pregnant, you have to wonder it is physiological or pathological. But anyway, so children, young and pregnant women in their third trimester pregnancy, when it is volume overloaded in third trimester. Then athletes which have well trained their cardiac system, and especially during exercise when there is rapid inflow of blood in the pliable ventricle, they may also have third heart sound. But now we come to the pathological third heart sound, causes of. Remember, whenever third heart sound is more than 40 years, think of some pathology, right? What are the two main mechanisms? Why it should be there? Number one, the heart should be pliable ventricle plus rapid, what is this? Rapid ventricular filling. Very rapid or ventricular fluid overload. Now here the causes can be at least two causes you must know. I will tell you many more, but two causes you must know, right? The two causes here are, number one, heart failure. In patient with heart failure, ventricle may be distended, and at the top in heart failure there is fluid overload and ventricular filling becomes too rapid. Why? Because if there is systolic ventricular failure, ventricle poorly contracted and stroke volume is less. So and systolic volume, that after the systole, the blood which is left in a failing heart, failing ventricle is too much, and little rapid inflow will lead to vibration. So number one, heart failure or congestive cardiac failure. And number two, MR, mitral valve regurgitation. It produces heavy inflow of the blood. How? Suppose this is a patient in which there is problem with the mitral regurgitation. In patients with mitral regurgitation, what's wrong? That when left ventricle contract, normally mitral valve should close and eventually aortic valve should open and blood should move into aorta. But if this valve, what is this valve? Mitral valve, due to any pathology does not close well, and blood can return back to atria, then there's trouble. What is the trouble? When ventricle contract, there is regurgitation of mitral valve, and not only blood goes into aorta, a lot of blood backfires into atria. Then atria become too much overloaded because atria receives the blood during systole of the ventricle and also receives the blood from venous return. And this atrium at the ventricular diastole will throw a lot of blood because it was overfilled due to regurgitation and due to normal filling, and that may produce third heart sound. Am I clear? So minimum you should know two causes of pathological S3, heart failure and mitral regurgitation. Then S3 can also be produced in all those conditions where there is hyperdynamic circulation. Circulatory system is very fast, and due to that reason there is very rapid inflow in the ventricle and producing the third heart sound. Classically it can be seen in fever, it can be seen in severe anemias, hyperdynamic circulation, it can be seen in thyrotoxicosis, raised T3, T4, right? So in the end, third heart sound, again I will repeat, might be produced, it may be very important finding in coronary care unit, a new third heart sound. I mean, in a patient where you repeatedly examine the patient pericardium, right? If previously when patient came there was no S3, and while patient is admitted S3 develop, it means ventricle is going out of work. There is some dysfunction developed. Is that right? So we say presence of S3 in coronary care unit is a dangerous sign, right? Especially in those patients who have crescendo angina, worsening angina, or patient with recent MI. Am I clear? Really? Now we come to the causes of S4. What could be the causes of S4? As I told you, S4, whenever you hear, it should be regarded pathological. Always pathological. You are given the liberty to enjoy S3 in young age, but S4 is not welcome. Right? Why? S4 will be only there when there is left ventricle stiffened. It failed to relax properly, and atria are straining to fill the last part of ventricle blood. Clear? Now, what could be the reasons? Anything which produces ventricular hypertrophy. For example, aortic valve stenosis, systemic hypertension. Someone has systemic hypertension, high blood pressure, right? Because a ventricle has to push the blood against high pressure, gradually it will become hypertrophied. And this hypertrophied ventricle does not relax well, and it becomes a sort of stiffened ventricle. Then atria has to contract very strongly to fill a thick-walled ventricle and produce S4. Right? So this can happen when there is resistance to forward flow. The causes of overflow, resistance to outflow, which may lead to pressure overload. Ventricle has feeling more pressure. It has to beat against more pressure, pressure overload, like aortic valve. First of all, systemic hypertension. Then aortic valve stenosis. And then there can be hypertrophy here, hypertrophic obstructive cardiomyopathy, right? But if you want to remember only two causes, right, 2 or 3 causes, you must remember systemic hypertension, aortic valve stenosis, and third very important is active ventricular ischemia or recent MI or patient with severe angina, right, especially unstable angina or crescendo angina. In these cases, when ventricle is under severe ischemia, it does not relax well, right? And then atria has to contract strongly to push the blood into that, right? So the conditions in which there is stiffened, either due to hypertrophy or due to failure to relax. Classically, you must know hypertension and aortic stenosis. In addition to that, you must know cases in which there is an active ventricular ischemia. Is that right? And then here heart is dilated, here heart failed to dilate properly. Here heart is distended and dilated. That is why here we can add one more cause, dilated cardiomyopathy. Here we can add one more cause where ventricle do not relax well, like restrictive cardiomyopathy. But if you cannot remember many causes, just remember 3 causes here: heart failure, MR and active ischemia. Here you remember systemic hypertension, aortic stenosis and active ventricular ischemia. Is that right? Now, after discussing all these things about S3, now I want to mention something very special. How do you differentiate? You know, S3 is very near to the S2. S3 is very near to S2. Now, this sound, as I told you, loop dup ta, loop dup ta, loop dup ta. Sometimes you are confused that this double sound is extra third art sound or it is split of S2. Sometimes S2 split, as aortic component may come early and pulmonary component become late. Now sometimes there is a confusion. You hear loop, then either dub is split or just after the dub you hear S3 and you are confused. Is it true S3 or it is just split S2? Very easy to differentiate. As you know, this is soft sound, low frequency sound. This is harsh, high frequency sound. So simple as that. If you put a bell here on apex and you hear double sound, after the loop, at the timeline of the dub, you hear double sound and you are confused. Is it split S2 or S3? Very simple. You turn the diaphragm there. Diaphragm will filter the soft sound. After putting the diaphragm, if you don't hear the double sound, if you do not hear the double sound, it means there was, with S2 there was S3 which disappeared on diaphragm application, right? But if you still hear the double sound, it is split S2. Again I will repeat. As S3 is very near, just followed, just after the S2, sometimes S2 with S3 are confused with split S2. How to differentiate? Simply, when you apply the diaphragm, S3 will, if there is really S3, it will disappear. But if there is splitting, then double sound will be still there. Clear? Same. S4 may be heard with, confused with split S1. S4 comes just before the S1. So S4 may be just heard before S1, or you may be confused the double sound which you hear at this time, it may be at the onset of ventricular systole, it may be S1 split. Very simple. You put the stethoscope, if with the bell you hear double sound, right? After that you put the diaphragm. If on the diaphragm double sound remain there, this is split S1. If double sound disappear, it means the disappearing sound was S4. Is that okay? Yes. Any question up to this? Do you have any question or you want to ask anything? Now we will make a very fast review and you will help me. I will ask you a question and you will answer me. Number 1. If rapid ventricular filling produces a sound in a distended taut ventricle, sound is 3. If atria strongly contract against a stiffened ventricle and sound is produced, it is S4. If sound is early diastolic, it is S3. If late diastolic, S4. Is that right? If sound is third art sound is better heard on apex and not heard on left lower parasternal, it is which sided sound?
Left side.
Left sided S3. Is that right? Then I will ask a question that if you want to accentuate left-sided sound, you will hear during inspiration or expiration? Yes, you should hear expiration. If right-sided sound, right, if you want to hear more clearly, you should hear during inspiration. Very good. Then another thing. I will tell you the cause, you tell me which sound you will expect. If there is aortic stenosis, right, and left ventricle is hypertrophied, you expect third heart sound or fourth heart sound? S4. If there is dilated left ventricle, right, and there is fluid overload condition in the body, which sound you will hear? S3. Now you will recognize the sound. You will tell me the pattern. Lup dup ta, lup dup ta, lup dup ta. Good. S3 gallop. Ta lup dup, ta lup dup, ta lup dup. S4 gallop. Very good. Lup dup tata, lup dup tata, lup dup tata, lup dup tata. Quadruple gallop. And if the sound is lup dup tha, 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 tachycardia going on, summation gallop. Okay? Class dismissed.